than with a partial deafferentation, and the asymmetry is greater with a total deafferentation than a partial deafferentation. This is simply another way of showing when these covert and overt saccades occur. Here's a healthy subject showing the profile of eye velocities, and here in grey we show increasing head velocity. The darker it is, the higher the velocity, and you can see the very few corrective saccades that occur quite late. Here's somebody with unilateral loss and overt saccades. All the saccades are occurring where after head movement is over. They are visible. Here, most of the saccades occur during head movement. They'll be invisible. These will probably be visible, but they may be too small to be noticed clinically. While the patient fixates the target, the examiner... This is how the video head impulse test is done. This whole test can be done with video. Overt saccades, which occur after head rotation, are the telltale sign of canal paresis, whereas covert saccades, which occur during head rotation, are not detectable to the naked eye. The patient puts on the lightweight video goggles and then looks at the center of crossed lines from a built-in laser to calibrate the entire system. Now, while the patient is looking at a target on the wall, the examiner briskly rotates the patient's head to each side in random order. During the test, the examiner has instant feedback about head velocity profile and the corresponding vestibulocular reflex eye movement of every single head impulse. The examiner can analyze and discuss the results with the patient immediately, since the software analyzes the data at the touch of a button and displays intuitive 3D graphs. In summary, video goggles are easy to use in a clinical setting and provide an instant objective record of the vestibulocular reflex and detect both overt and covert catch-up saccades in vestibular patients. So here's a recording showing data with scleral search coils, which of course is a research tool, and with video goggles in somebody with a left vestibular lesion. Here are the head impulses to the right, and here are the head impulses to the right with video and coils. You'll see they're identical. These are recordings made at the same time. So you can see every single eye movement that is there in the coils is there in the video. This is to the affected side, and you can see head impulse with the coils, lots of covert saccades occurring during head movement, some overt saccades afterwards, and every one of those saccades is present in the video recording. The profile of the residual vestibulocular reflex is very similar, and if it's plotted as gain, you can see here straight away this is the affected side in dark, which is the off direction of the remaining canal, and this is the on direction, and you can see the gains are very, very similar, both with video and with coils. So in most patients, you can get diagnostic results using a video system for measuring head impulses, and it's possible to recognize those patients with covert saccades who have a false negative head impulse test. And the danger of a false negative head impulse test would only be that one can falsely diagnose a cerebellar infarct in someone who has an acute vestibular lesion. But as a false positive, it's safe, but as a false negative, it's quite dangerous. And it's very important that in somebody with a positive head impulse test, not to diagnose cerebellar infarction. This patient's had a posterior inferior cerebellar artery territory infarct, not with occlusion of the artery, but a paradoxical embolus through a patent foramen ovale. The head impulse test is a reliable way of distinguishing cerebellar infarction, if it's negative, from acute vestibuloneuritis, in which case it's positive, in a patient having their first ever attack of acute spontaneous vertigo. Impulsive testing can also be used in bilateral vestibular loss. gentamicin vestibulotoxicity being a frequent cause of it. Here's a patient with severe bilateral vestibular loss due to gentamicin, and on impulsive testing, the catch-up saccades are visible, overt, to both sides straight away. In slow motion, 1, 2, 3, 4, 5, there's the catch-up saccade. This person has a severely defective, if not absent, horizontal vestibulocar reflex. This is a recording of with scleral search coils of what we just seen. Here's the head velocity profile, and one can see straight away that there's a markedly deficient vestibulocar reflex with a whole series of overt saccades afterwards, the same patient. This is the same patient recorded with video. This is with coils, this is with video, and you can see straight away, here's the residual vestibulocar reflex from the left lateral canal, here from the right lateral canal, with a whole series of catch-up saccades, all overt afterwards. A quick, easy way to diagnose bilateral toxicity, and the gain of the vestibulocar reflex is under 0.2. This is a patient with severe vestibulotoxicity. Here's the gain in a normal. Here's the on-direction gain in a unilateral patient, the off-direction gain, and the gain in a bilateral patient severely affected is below that. And if we now take 14 gentamicin vestibulotoxicity patients, here shown in yellow, one can see that there is a whole range of vestibulocar reflex gain deficits overlapping with the low range of normals, here shown in red, and here shown as ISO VOR curves, 10, 20, 40, 60, 80%, showing that there's a continual spectrum of bilateral vestibular loss from gentamicin toxicity, and most importantly, these deficits are already visible at low head accelerations. All this data is available. It's all been written up, all in the journal Neurology. This is showing the Headimpulse test in unilateral vestibular loss. This is a Headimpulse test in bilateral loss due to gentamicin toxicity. This is how video Headimpulse testing works, and this paper tells us that Headimpulse testing reliably differentiates cerebellar infarction from vestibular neuritis. So the take-home messages are several. Number one, severe unilateral loss of lateral canal function invariably shows up as catch-up saccades during rapid passive head rotation. The saccades, however, can be visible, overt, or invisible, covert, and then only obvious on measurement, which is easily done with video recording goggles. It's essential for unilateral vestibular loss to rotate the head quickly and to maintain fixation. Both the patient must keep looking and the observer. If the observer blinks, the observer will miss it. The whole saccade is over in 80 milliseconds. Graded head impulses can quantitate the input-output relationship or the gain of the vestibulocar reflex. Head impulse testing with high accelerations reveals vestibulocar reflex deficits better and elicits larger overt catch-up saccades in unilateral patients. Faster you go, the more obvious it is. Covert catch-up saccades occur frequently and will be missed by the clinician. You need to apply fast head impulses, repeat the head impulses several times, and you need to some method of recording to detect covert saccades. A false negative head impulse test will lead the clinician to suspect the central vestibulopathy, which will lead to an unnecessary imaging, but it won't lead to any danger. Gentamicin vestibulotoxicity patients show a spectrum of vestibulocar reflex deficits from almost normal to total loss. In contrast to unilateral patients, the deficits are already marked at low head accelerations, and the head impulse test correlates well with caloric and rotational testing. Covert saccades are not as frequent as in unilateral vestibular loss patients, but might be present even in total bilateral loss. The Headimpulse test, we think, is useful for detecting early gentamicin toxicity at the bedsides, mainly due to the large overt corrective saccades. Thank you very much, and the work on this is continuing in Sydney and around the world, and I'm sure we'll see a lot more results with video Headimpulse testing to measure these deficits. Thank you.